Our village chief, of course, is Teresa over there, and we couldn't make this happen without her. And then the board members and the advisory committee and program committee all spend a lot of hours and time choosing speakers and topics and putting the conference together. I think we should recognize also the everyone who works at registration puts in a lot of time and effort, and Davis AV over there and Weber State, Physician Wealth Advisors does our finances, and Child Richards our accounting, and so all of these are, you know, people and groups and organizations that make this happen. So it's now my honor to recognize the president for this year, Adam Tainter, and come on up, Adam. And we have a tradition of we have a tradition of presenting the gavel to the president. So probably the first responsibility of the president is to pick a theme. And if I remember right, originally Dr. Tainter's theme was AI. Is that right? And then switched to dermatology, and both are great topics. But I think the thing that is great is we actually got both. And dermatology is one of those topics that I think everybody in medicine loves. And no matter what specialty you're in, dermatology is relevant. Even an orthopedic surgeon probably gets asked about, you know, something related to skin from family or friends or someone. But we all deal with dermatology in our clinics to some degree. And so this year we've had great speakers, great topics, great variety, breadth. We try to have a gamut of things that are talked about. And Dr. Tainter is very well connected, knows a lot of people, and has a lot of great ideas. And I think that was reflected here in all the speakers and topics and everything that we were able to present. So I'd like to give Dr. Tainter the gavel and thank him for a great conference. So please join me. Too many counts. Okay, sure. Okay, and just really quick, we used to go over all the reports, but now we've made it simple. And so if you're interested in seeing the financial report, CME report, it's on our website, as well as obituaries. We don't actually have any 50-plus year people to honor this year. We usually have that, but not this year. Okay, and then the last thing is I'm going to turn the time over to Crit Ardema, who is going to talk about what's coming next year.
It's an honor to be here, and I'll tell you what, as I sit through this conference, sitting in this position as president-elect, I think it makes me more intimidated and worried and excited about next year. Well, I just want to say a couple of things that I love. Number one is I love family medicine. That's what I do professionally as my family doc. And I love physical activity. It's also just part of what I do. And as I was thinking about my theme and what areas of medicine I'd like to focus on a little bit, I started to think about my role in family medicine. And I think our industry, we do a good job about preventative medicine in terms of vaccinations and colonoscopies and mammograms. But I don't know how good we are at encouraging physical activity. We may mention it, encourage it, but I don't know that we spend a tremendous amount of time focusing on the benefits of it. And as I sit and I look at my patients, I've realized there's a fountain of youth out there. And that fountain of youth, proverbially speaking, is physical activity. Last night, we went down to the pickleball tournament, and for those who weren't there, you missed out. But you got an opportunity tonight. Tonight at 5:30 over at Mount Ogden Park, we have those pickleball courts reserved. Well, there were a couple of really old guys there, Brian Campbell and Joe Porter. And those two really old guys mopped the floor with the rest of us young guys. But as I sat there and I was thinking about what I was going to say today, I looked at those two and I thought, they're drinking from the fountain of youth last night. And that is they're moving, they're staying active. So the theme next year is entitled Movement in Medicine. And it's intentionally a little bit of play on words. So we're going to focus a lot on the musculoskeletal side of it, the movement side of it, but also movement in medicine in terms of where is medicine moving in the future, the political side of it, the international side of it. So we are excited about the opportunity next year. We'd love to have you all there, and thank you for giving me this opportunity.
Okay, everyone. Good morning. My name is Scott Moore, and I'm a current member at large, board of director in charge of Ogden Surgical Policy Governance. I wanted to say just real quick, let's put a plug in for the bookstore. If you haven't been there, go check it out and go buy a book there so they come back next year, because we'd like to have that at our conference. It's good. Also, thank you everyone for throwing away your own plates. This time it actually saves us quite a bit of money, and in fact it saves you guys money too, because then you guys don't have to pay for the service. So also please visit the poster presentation over in the back hall and submit your ballots. If you submit your ballot by noon, then it'll be counted for the contest that we have. Today at 7:30, I want to welcome Dr. Michael Sherman. Dr. Sherman's lecture is sponsored by Ogden Surgical Partner Common Spirit, Holy Cross Hospital Davis, and Tanner Clinic. Please stand if you're associated with Common Spirit or Holy Cross Hospital Davis or Tanner Clinic. All right. So Michael Sherman completed his Doctor of Medicine degree at University of Rochester School of Medicine. This is cool. His internal medicine residency at SAWSHEC, San Antonio Uniform Services Health Education Consortium, and his fellowship in gastroenterology at the Naval Hospital Center in San Diego. He also received his master's degree in bioengineering at the University of Utah and his Bachelor of Science in Chemical Engineering at Brigham Young University. Dr. Sherman is board certified in gastroenterology, and he seeks to provide thorough, compassionate care of his patients' gastroenterological diseases and symptoms. He cares for his patients' autonomy and endeavors to provide them with the most accurate information so they can make informed decisions regarding their own care. So let's give it up for Dr. Michael Sherman.
Well, I am thankful for the opportunity that I have to be here today. It's my first time at this conference, so it's nice, and I appreciate the chance I've had to meet so many of you. My topic today is one that I have a lot of passion for. I'm going to talk about colon cancer screening prevention, or colon cancer prevention, and what the screening options are and how they compare to each other. So, first of all, as a gastroenterologist, I am, hopefully not too often, but I am in the position of informing patients of their colon cancer diagnoses, and have the chance to look back and see either what went wrong or what we could have done better to prevent that from happening. And so as gastroenterologists, we are in a key position to be able to see the system and what's working and what we can do better. So on a personal note, there's one reason that this topic is so important to me because it has affected my family. Kudos to my aunt's OB-GYN who diagnosed her early. She was young when she was diagnosed with colon cancer, and thankfully she received excellent medical care, and this was in our area, and since her treatments has followed up with serial colonoscopies and polypectomies and is doing well and is with us today. Recently I asked her, when she was diagnosed, she was counseled by her physician to counsel her close relatives to get colonoscopies at that time, and she says she did. My uncle, my dear Uncle Brian, somehow we lost him to colon cancer a few years after that. So he would have loved to be here today. He was a huge Weber State fan. He was an alumni. He ran the steeplechase at Weber State. He raised a beautiful family, served in his church and community. He served actually in the Clinton City Planning Commission for years and was an auditor for the state of Utah. Tragically, all that was interrupted with his colon cancer diagnosis and passing away from that about a year and a half afterwards. Lots of reasons, some of which we understand, some of which we don't, that may have contributed to this, but the bottom line was that he did not receive his first screening colonoscopy until he was 61. So because of his experience and for many other reasons, this topic is, I have a passion for this and a desire to really help improve our system and prevent others from the same outcome that my uncle went through. So the one nice feature of colon cancer is that it's slow developing and that we have the opportunity of preventing it. Usually there's a 10 to 15 year lead time between a normal colon and colon cancer where we can find polyps, remove them, and prevent that from happening. So colonoscopy is the only preventive screening option. And it is also the only option that's been approved for polyp and colon cancer surveillance, for the evaluation of symptoms that the patients are having, or findings, like imaging findings. It's also the only screening option approved for patients who are high risk, those with either a family history of colon cancer or high risk colon polyps. So before I jump in, I wanted to give a short introduction to some of the polyp types, and these are important to know to be able to interpret the differences in the screening options. So tubular adenomas are bread and butter. They're the most common type of precancerous polyps in the colon. We find these almost half the time we perform colon cancer screening colonoscopies on average risk individuals. Sometimes these are small, they can be flat, they can be pedunculated, they can be easy to find, sometimes they are difficult to find and remove. The second type of precancerous polyps are sessile serrated lesions. In the past, these have been called sessile serrated polyps or sessile serrated adenomas. These are less often, but these are our challenging polyps. They're difficult to find, they're flat, they often have a mucus cap, and they just can be difficult to find, difficult to remove as well. The third type are called advanced adenomas, and these are almost cancers. These are either large tubular adenomas or sessile serrated lesions, or they can be polyps that have developed additional mutations and are almost at the point of being cancers. And we find these about 5% of the time in average risk screening individuals. So just to calibrate you on what we do, I went back and looked at 100 of my average risk screening colonoscopies last October and just counted up how many polyps there were that we removed and also how many cancers I found. So that calibrates you when you send your patients, these are average risk screening patients. When you send them for colonoscopies, we actually are doing a lot of work to remove these polyps, and all these polyps removed significantly decreases these patients' risk of developing colon cancer. So there are alternatives to colon cancer screening. Stool tests, a couple that are popular and currently approved. There's the FIT test, which is the upgraded fecal occult blood test. That one is performed annually, and any positives would be referred for a colonoscopy to evaluate the reason why. Cologuard is heavily marketed. It is a combination stool DNA test along with a FIT test that's included. So a positive on the Cologuard could be triggered either by the FIT test part or the stool DNA part. And that test would be performed every 3 years, again with a colonoscopy follow-up if that's positive. There are two new blood tests that have recently been approved by the FDA, the Shield and the Freenome. Those also would be performed every 3 years and followed up with colonoscopy if those are positive. So, a lot of numbers on this chart. These are the reported sensitivities of each of the tests for not only cancer, but for each of the polyp types that I mentioned. So the big takeaway from this is, number one, that colonoscopy is not perfect, okay? The sensitivity for advanced adenomas is reported around 90%, and for the precancerous polyp types is not perfect either, 75 to 85% for the tubular adenomas, and a little lower than that for the sessile-serrated lesions. For all the other tests, the sensitivities for precancerous polyps is the other takeaway. It's very low. The tests just don't find the precancerous polyps often. So a lot of numbers in trying to compare these. So there was actually a group recently from Stanford, Oregon, and Pittsburgh, a few other places, combined their knowledge to crunch all these numbers for us and try and answer the question that we really want to know, and that's what is the risk of dying, either getting colon cancer or dying from colon cancer, when we compare each of the strategies, whether it's colonoscopy, Cologuard, FIT tests, or the new blood tests. So their results in graph form are a little easier to see. The graph, the grouping on the left represents the lifetime risk of developing colon cancer at all in these, and on the right is of dying from colon cancer. The tall black column represents the risk of developing colon cancer with no screening whatsoever. So that's about a 7.5% chance of developing that with no screening. That drops to around 4% with the blood test. The two next columns are the two blood tests. The next four columns are the stool tests. There are three different variations related to Cologuard, and the annual FIT testing is the orange column. The lowest column is colonoscopy, with representing about a 1.5% lifetime risk of developing colon cancer. So let's jump now to the real world. So away from just looking at studies and crunching numbers, what is colonoscopy in the real world? And then we'll do the same with Cologuard and try and compare those. So colonoscopy in the real world, as we all know, can be challenging. The system challenges can make this difficult. Getting the patients to perform an adequate bowel prep so that we can actually see in there can be a challenge. And then the other steps, we have to get the scope all the way through the colon, find and remove all the precancerous polyps, document those appropriately, and then convey the recommendations to you all. Our goal is that we are able to do this even to referring providers outside Tanner Clinic. It's easier within our system because our providers can see what we're doing, but if you are a provider that refers your patients to us and are not getting back either the procedure reports or our recommendations for follow-up, please let us know. Our goal is to make sure that you have this follow-up information and we coordinate the best that we can to make this possible. Colonoscopy is operator dependent, meaning it does make a difference who performs the procedure. There is a difference. So it's a procedure that is performed both by gastroenterology, surgeons, and primary care physicians. Over the years, there have been a lot of efforts to try and eliminate the differences and standardize this. We have a society that's focused on this. New guidelines were just recently released for us on what we should be focusing on, what the most important features are. Out of the priority quality indicators, there are two that I wanted to focus on: the adenoma detection rate and the sessile serrated lesion detection rate. So the ADR is defined as the percentage of screening colonoscopies where we find at least one tubular adenoma. It's been our gold standard quality indicator for decades because it is clearly associated with the patient's risk of interval colon cancer. So interval colon cancer is our nightmare. It's defined as when a patient has done everything that they were supposed to do. They had their colonoscopies, they were on time for everything, and they still developed colon cancer. So it's the last thing we want. So if we have a high ADR, a high adenoma detection rate, that decreases the chance that the patients will develop colon cancers before their next interval. So how are we doing locally with this? So thankfully, IHC tracks our adenoma detection rate of all of the providers that perform colonoscopies at their facilities. Our target is to have our ADRs over 25%. And I took all the data from 2024, and the vast majority of our providers are above the target in this area. So we have good care available in our area in colonoscopy. How are we doing with the sessile serrated lesions? Again, the majority of our providers are above the target of 6% with these rates. As you can see, there is a significant amount of variation in the detection rates on both of these. Does that matter? So it does. So if you take our top performer with an ADR of 44 and compare it to the lowest performer of 14, there's about a 90% lower risk of developing interval colon cancer if you happen to go to the provider with a higher rate. So not all the facilities in our area are measuring these quality indicators. Both IHC facilities and Ridgeline does. And there are providers in our area that do not scope at those facilities where their measures are not tracked, at least by those facilities. So what's the takeaway from this? If you are referring your patients to a provider and you don't know what that provider's ADR is or quality, I would encourage you to ask that provider. They may have that information. We receive quality reports from both facilities quarterly to see how we're doing, and so we have that information, and I'm always happy to convey that to you and help you know that your patients are receiving quality care with that. One thing to note, in the real world of colonoscopy, there are improvements coming. There are several ways that AI is coming to augment the care that we receive, both in helping us identify polyps during the colonoscopies and also helping us be able to measure these quality indicators more easily. So jumping to Cologuard in the real world. So there are a lot of numbers on this chart. Basically, this was a large study that was performed up in Wisconsin, where they took almost 7,000 patients who had received Cologuard as their screening option for average. They were all average risk. Of those almost 7,000 patients, close to 20% were positive. Out of those 20%, most of those received colonoscopy. There were some that didn't follow through with the follow-up colonoscopy for several reasons. Some of them refused to schedule, some said they scheduled and didn't, and some the follow-up colonoscopy was never ordered by the primary care provider. And then there were about 10% of these patients that tested positive that didn't receive their colonoscopy because they medically weren't fit for colonoscopy or passed away in that time. The one point I would make is that for these patients, there actually is no medical benefit to performing a Cologuard or any of the other colon cancer screening options if they're not medically fit for colonoscopy as the follow-up. They don't get any benefit from that. Out of those that did follow up with colonoscopy, only about 1% of positive Cologuard results turned out to be cancers. There were a lot of polyps that were removed during those follow-up colonoscopies. So I love this study because we can use this study to calculate some quality indicators in the real world for Cologuard, and then use those to compare against the real-world colonoscopy results that I just discussed. So if we take these numbers, we can calculate Cologuard's adenoma detection rate. So it comes out to around 6.4%. That's the percentage of those screened originally who had tubular adenomas in their follow-up colonoscopy. So how does that compare when you put that in the chart versus individuals in our area who received colonoscopy for their screening option? It's well below our guidelines and much lower. And if you take that and use that to calculate how that impacts their risk of developing colon cancer, that ADR of 6.4% correlates to 2 times the risk of interval colon cancer versus individuals who receive their colonoscopy receive their screening with high-risk colonoscopy or high-quality colonoscopy. How does Cologuard do with the sessile serrated lesion detection rate? We can calculate that as well. It comes out around 1.5%. And that also stacks up well below our goal of 6% with the sessile serrated lesion rate. So the final takeaway, why does Cologuard underperform on these? The big reason, we can actually take the number of patients who receive their Cologuard, the 7,000 patients, and we can calculate how many precancerous polyps they had based on our minimum standards for ADR and sessile serrated lesions and advanced adenomas. There should have been at least almost 5,000 precancerous polyps removed if these patients had received colonoscopy for their first time, where in the end they only had 550 removed. So almost 90% of the precancerous polyps in the original group were not removed. So bottom line is a lot of those patients who went home with reassurance that their Cologuard was negative had precancerous polyps inside that then subsequently grew, and they were at risk of developing colon cancer during that time. So it should be noted, a couple years ago, 2023, the ACP actually recommended against using Cologuard as a colon cancer screening option. They incorporated the cost factor of Cologuard along with the quality, and for various reasons as noted up there. The other mention I would make about cost, the cost of the different options is often blind to the patient. The patients are blind to that because of the Affordable Care Act. Affordable Care Act provided a freebie, basically. So patients get a free colon cancer screening when it's due through the Affordable Care Act. So either a free Cologuard, free FIT test, or free colonoscopy with everything covered. What gap there is that not all insurance companies cover the follow-up colonoscopy for positive FIT tests and Cologuards as a screening. And so there is a group of patients that receive their screening with Cologuards or FIT tests that are positive and then follow up with the colonoscopy and have to pay significant copays and deductibles. I've had patients walk away having performed the prep and arrive and find out that there's going to be a copay and a cost, and just decide not to do that follow-up colonoscopy. So moving on to the new blood tests, we currently do not have any real-world results yet from these to compare their outcomes to the stool test or colonoscopy. These are brand new tests. I imagine that it would be a similar outcome to the Cologuard graph with differences based on the different sensitivities. So what can we do to improve in our area? There's a few things. So the screening recommendations of getting the first average risk, the first colonoscopy or screening in average risk individuals at 45 instead of 50. Family history is defined as having either one first-degree relative or 2 second-degree relatives with either colon cancer or advanced adenomas or high-risk polyps. For those high-risk individuals, they would start either at 40 years old or 10 years younger than when their relatives were diagnosed, whichever is earliest. It's not multiple choice. Many patients would take the later rather than the earlier. The next thing we can do is utilize the most effective colon cancer screening option. There currently are many unused spots in endoscopy spots for colonoscopy that are not being used. The other thing to do, as I mentioned, is find out the quality that's being provided by the endoscopists that you're referring to, and refer to those endoscopists who are tracking and meeting the quality standards. The next thing is, when you're presenting colon cancer screening options to the patients, I encourage you not to advertise the second-tier options as equivalent options. Recommend colonoscopy as the primary option. And then for the niche that Cologuard and FIT testing does fit into is for those patients that refuse colonoscopy, but if they had a positive test on their Cologuard or FIT test, would follow up with colonoscopy. The last thing, don't use the stool tests or blood tests inappropriate, meaning those tests are only approved for average risk colon cancer screening. They're not approved for high risk individuals, not approved for surveillance of prior cancer or of prior polyps, and they're not approved for the evaluation of symptoms or findings. For example, when a patient comes and reports blood in the stool or on the toilet paper, there's not any indication to perform a stool test to find out if that blood they saw was real. There's not any indication to perform a Cologuard on that patient to find out if the blood was due to a cancer. That patient has an indication for colonoscopy. Please refer them for that colonoscopy to evaluate their finding. The surveillance recommendations after patients receive colonoscopy depends on the types of polyps they receive, the number of those polyps, and their family history. We try to convey those recommendations. If you're not receiving those, again, let us know. And the population health recommendations should align with the recommendations we give. Sometimes those recommended surveillance intervals can be different depending on what we see and the experiences we have during the colonoscopy, so they can vary. And one group that one issue we often have to address, a lot of patients have the idea that colonoscopy is not available or performed or offered or recommended when they are beyond the age of 75. So it's simply not true. So for screening, for average risk screening, we do stop average risk screening in individuals sometime between 75 and 85, depending on their own health. We all know those 75-year-olds that look like they're 40. They obviously should continue their colonoscopies. For polyp and cancer surveillance, we continue that surveillance as long as the benefits continue to outweigh the risks, even beyond the age of 85. So we have a handout that hopefully makes it easy, summarizes a lot of the information that I've covered, and hopefully facilitates your discussions with your patients in making this decision of what option to go with. We're going to have a link on our website, on the Tanner Clinic website. If you go to the Tanner Clinic website to specialties and then gastroenterology, there will be a link there. It's not currently active, but should be by next week, where you can download this handout and use this in your discussions with your patients. So thank you again for the opportunity to discuss this, and I hope that this was helpful for you. So, yes. Any questions?
So thank you for the talk. That was great. You know, a lot has been said at this conference about value-based care in healthcare organizations. So one of the things value-based care says to primary care doctors is the more people you screen for colon cancer, you know, the better your quality of care is. But that doesn't say what kind of screening. And so the fact is we capture more people by doing FIT tests, which I guess is both good and bad. We do get some people who screen who wouldn't have done so otherwise. But then there's also a lot of people who opt for the easier option and bypass the colonoscopy. So I don't know if you have any comments on that, but that's sort of the trend over the last couple of years.
Yeah, so I'm not sure I would agree that it's a trend over the last few years. There was a large, actually it was Kaiser in California, made a big push to use the FIT test, and they basically put the FIT test as a requirement to do any lab testing or refill prescriptions, and really helped capture a lot of that group that we're really looking for, the group of people that just don't want to do colon cancer screening. And that actually, in their area, that actually increased the colon cancer screening rate, not just because of the FIT test, but because of the follow-ups. So again, my hope is that it's conveyed to patients that FIT testing is an option, that it's not an equivalent option, that if they choose the FIT test option, the idea is that they would follow up with colonoscopy if it's positive, but in that option, they are at a significantly increased risk of developing colon cancer rather than if they choose the colonoscopy option to start with, because FIT tests do not find precancerous polyps. Yeah.
Great presentation, and thanks for the emphasis on quality for our patients. One of the barriers that I've had within primary care is making sure that patients get the referrals to whichever colonoscopy location they're going to, whichever GI physician. Sometimes I'm told that the insurance companies require that referral to be placed, which creates, again, this frustrating barrier to care. Can you clarify at all whether it is required for these routine screenings to be had? In mammography, patients now can show up and just get their mammogram done, at least on a screening basis. How does that compare with colonoscopy?
Yeah, no, I appreciate that. So I can't speak to every insurance provider's requirements, but referral is definitely not required. So actually on the handout that you can link to, that I referred to, the patients actually have a number they can just text to directly schedule their colonoscopy without any referral that's required, or they can call to make that appointment. If you choose to place a referral to us, that engages our system of actually calling them multiple times, and if they don't respond after the third time, we send them a letter, so they get that extra emphasis in getting it. If it's up to them to call, it's up to them to call. Some will, some won't. So if you want us to help engage them in that with those extra efforts, please place the referral. Yeah.
I've got two questions, and first off, I think you did a very non-biased job in presenting all of that data. It was great. My questions I want you to be biased for. The first question is the older patient. Yep. They don't reduce their risk of colorectal cancer, and yet the screens are suddenly no longer paid for. What would you do with the older patient?
So I'm not sure what you mean by the screenings are no longer paid for. I'm not aware of the benefit of the colon cancer screening not being paid for after the age of 75. We do keep going. Again, average risk, meaning they've never had a precancerous polyp and they have no increased risk, no family history of colon cancer. So we'd keep going with screenings until somewhere between the age of 75 and 85, depending on their health. My understanding is that's still covered by insurance in the Affordable Care Act.
I don't believe that's true, actually.
Okay.
So I think there is a
So we
cutoff
can
age
check on
with
that.
Medicare.
Yeah.
Yep. What I've been doing is recommending a FIT test to my older patients. I have nonagenarians that I feel it's not appropriate to just say, okay, you're going to die, so don't get your colonoscopy.
Yeah.
Although I don't want them necessarily to undergo the prep.
Yeah. So the one point I would make in those patients, I agree that if they should be receiving their screening, and preferably with colonoscopy. I'm not sure on the cost part. I have to check on that. With those older patients, oftentimes they're on anticoagulation. They have hemorrhoids. Those tests are going to be positive, and that's going to flip that to a diagnostic test in many. If that enables them to get their colonoscopy covered, by all means, that makes sense.
Now to the other extreme, the 45-year-old who obviously had a hemorrhoidal bleed, but came into my office and is sent for a screening colonoscopy, who's then converted to a diagnostic
Yeah.
colonoscopy, we all know it's the same scope.
Yeah, I wish the government didn't set up these different categories. When I look at that, when a patient's coming in for multiple indications, including their due for screening, as well as maybe having some blood on the paper or something like that, we always put the screening first as the first indication for that, and then bill that as a screening. There definitely are patients that are not due for screening that maybe had a colonoscopy a year or two ago, want to evaluate the blood, and still want that screening and come in, the free screening, and come in with that. If they're not due, sometimes we do have upset patients because we can't misrepresent that. So if they're not due for screening, it's a diagnostic if that's why they're getting the procedure. Yeah, and that doesn't mean it's not covered. It just means they may have copays and deductibles. Okay, thank you.